All right, and I found you on LinkedIn, and it was you posting about the hospital hostage / active shooter situation in York, Pennsylvania. So that was me.
Welcome to the New Jersey Criminal Podcast. Our producer, Tom, is joined by former Green Beret and healthcare security expert, Matthew Wainscott, to discuss the active shooter and hostage situation in York, Pennsylvania last week. We advise viewer discretion due to the nature of the topic. So please enjoy the conversation. And don't forget to subscribe at njcriminalpodcast.com or visit the NJ Criminal Podcast YouTube channel to subscribe for new episode alerts. Now, welcome to the NJ Criminal Podcast.
What was that post about, and what is it that you do that you have a unique perspective or a perspective at all specifically on healthcare hospital active shooter situations?
Yeah, so I work in a healthcare-based police department, and I just so obviously any of these stories I really zone in on. I also help teach a response to active shooter class for our bedside staff, nurses, and so I really try to drill into any incident involving a weapon in a hospital, absolutely. And there really has not been a lot of national media coverage on this incident, and so I've been drilling into local newspapers and who linked me to a post by Tosha Trostle, who was an RN in the ICU, and basically hands down, bar none, worst day of her life. There was an individual, they had taken care of his significant other that week, and based off a Facebook post from a PA who worked in the ICU, it sounds like they had to let her know that she had passed away, and there was nothing about him that made them think it was headed this route. And not sure the time lapse, although they do believe it was that week. He comes in Saturday morning with zip ties, a pistol, and a bag, goes straight to the ICU, ends up zip tying at least 2 nurses, and ends up dying by being shot by police in the exchange. But beforehand, he had shot at least 1 nurse, 1 environmental services worker, a physician, and 3 law enforcement were shot, 1 fatally. So, and then the picture of the nurse who, I hate to say it, but our society, it's just so easy for us to be numb or to not really dive into, think through that experience. But when you see her face, and if you can throw that picture, I'll send you a copy of the picture that I think is worth for those watching this. Man, huge bruises, 2 black eyes.
I saw that.
Yeah, so she was pushed into the ICU door. She was pushed into the ground. He lands on her. I mean, it sounds like she took 3 significant head injuries minimum in this exchange that she remembers, let alone what else. And so, for me, I came across that post, and it just felt like the national news story had already moved on. There was a lot involving Ukraine. There was, as we write this, Trump's still, relatively new to, we record this, Trump's still relatively new to the office. I mean, things are moving 100 miles an hour in the national news story. And it just felt like, man, we got to tell the story of what this nurse went through. I mean, I was mortified by it. And so that's where you just shared a post, a brief post trying to get the story out, and linked to her Facebook post on LinkedIn. I linked to her Facebook post on my LinkedIn account.
So what's the general level of security in an average hospital? And I'm going to guess it varies pretty wildly state to state.
It does. And I think it varies very widely on funds. And, like looking at some of the places, I would say most hospitals do not have any form of weapons detection system. They are increasing rapidly, but, there's very little on that front. I know California just recently passed some sort of legislature requiring that. I think what's interesting, why healthcare? Why does healthcare need those type of measures as a whole? And I think if you think of it, like, those are very access controlled environments. So areas like ICUs and emergency rooms, like it's funny if you get somewhere and lose or misplace or forget your badge, like, it can be hard to get out. Like you can be stuck very quickly. And so, if you think about like the other extreme of that environment, like a jail, right? At that extreme, it'd be very hard for law enforcement to get in and move around those environments. And so, I just think we need to be doing more because, the level of crime and violence we are seeing is rising. And, the amount of gun violence in hospitals we're seeing, obviously across the nation as well, is rising. And, and then we have this hostage, this gruesome exchange, where her eyes are so black and blue that her 4-year-old was afraid to be in the room with her, and then like, we're just moving off this news story very, very quickly. And so that, to me, that was where I have to continue to talk about this. And yeah, I mean, as a whole, from what I'm seeing, very, very limited protective, most, because you think about it, like an ER is open 24/7, 365. So at a minimum, these hospitals are generally very soft targets. And then two, I looked at UPMC the incident where this happened. They posted a $339 million loss for 2024. So, there's also these fiscal struggles healthcare is facing right now, to where even trying to get cameras at it or basic panic switches can be very challenging. It can take multiple budget cycles to request these things. So yeah, I think as a whole, our hospitals are very soft targets, and people know it.
That's interesting because you mentioned losses, and this conversation coincides with a reckoning in the business side of healthcare being wildly broken.
Correct.
And you would think the silver lining in the timing here might be that if the business of healthcare can be realigned in a way that's market driven and makes any kind of mathematic sense from anyone who knows anything beyond long division, like there's layer after layer after layer of preposterous schema that disrupts what should be a transparent customer provider relationship. It's so unbelievably corrupted and convoluted. We're one of two countries that has people picking their own drugs out before they've even been diagnosed with any kind of affliction, because we're only one of two developed countries that allows pharma advertising, which changes your healthcare conversation before your healthcare conversation starts. So that's a whole thing. But if the business side of healthcare could get aligned, this shouldn't be a weird conversation, because every other business that has smart people in it, educated people in it, big groups of interested stakeholders in it, seems to be able to manage the basic administrative functions. Sometimes that includes security. And for some businesses, healthcare would be in a group with lots of other businesses that have a heightened security necessity. So basically, it's simply part and parcel of the foundation of your business.
Yes.
If you're running a decent business model in any way, shape, or form, these things get addressed quite naturally, because it's part of the bare minimum you need to do to serve a clientele. And
with that clientele, an interesting layer to this is our safety nets as a community are just rapidly decreasing. And I think most people are aware of just how many mental health resources have evaporated, right? And so hospitals are stepping in, as that safety net role. But another thing to be lost, especially post-COVID, in COVID, jails became very restrictive as far as the types of patients or the type of prisoners they allowed in. And so they started taking less and less. And it's continued.
I had to apply 3 times before county would accept me.
Right.
I had to get an internship. They weren't impressed with my resume.
Exactly. And so we're seeing domestic violence suspects who, assaulted family members, instead of some of these assaults are heinous enough that these guys should be in jail. A doc I know, he's got a big heart. He's not arrest everybody kind of guy. Like he's like, he came up with the saying, and I posted this on my blog of like, prisoners, patients should go to the hospital, prisoners go to the jail. And we're not seeing that. Like what's going on is the jail's refusing a lot of these patients, pushing them on the hospital for these jail clearances to try and limit their liability if there's some kind of health issue. And so you'll see like essentially these police agencies dropping these guys off who are either there's mental illness, there's impairment, there, drugs, alcohol, whatever. And so, guys who probably should have just been sleeping off a hangover in jail for a night and kicked loose in the morning, they're in hospitals now. So instead of corrections officers who are trained and much more proficient at handling this, our nurses are bearing the front of this. And so, there's just been like a corrosion of safety nets that hospitals are absorbing because of, we don't refuse people from ERs, right? With EMTALA, like everyone is seen and everyone's evaluated. And so I don't think people realize just like the amount of things that are brought to hospitals now that in the past, either a mental health service, a jail, other services of society would have managed or handled. And even homeless shelters, even a decrease in homeless shelters.
There's a difference now when you say jails, are you talking about municipal?
Correct. County jails.
Okay.
Yep.
Interesting.
And I mean, some of it's legit. Like some of it's,
sure,
drugs and stuff these people are on. Like, I mean, they're in a tough spot. The complexity. Oh, I just smoked weed. Yeah, but it was laced with what, right? And some of these guys, I believe them. They don't know, right? Like, they're smoking weed laced with all kinds.
You're probably smoking Roundup in your weed. I mean,
yeah,
depending on where you got it. I mean, so
yeah,
don't discount the fact that something might be in your weed, bro.
Absolutely. Yes.
Forgive me. Go right ahead.
Well, and Tosha is just one of them. I mean, there was it is so far I'm working off of the brief of the day of the event from the district attorney and social media posts and local news media. But, there were others like, sorry if I'm pronouncing this wrong, but, Jessica Breighner was also zip tied, thrown to the ground. She's another nurse. There was an EVS employee named Jackson Enders, and both Jackson and Jessica have GoFundMe pages. Hopefully, we can get the word out on those. But, Jackson was shot in the thigh. It traveled down the thigh and hit the knee. It lodged in the knee. She had 4 surgeries. She's home. She's safe, but can't bend her knee. Long road. She had literally just turned 19, like days before this event. I mean, just a kid, like young, beautiful kid. You can see it on the GoFundMe, right? And so, I kind of wonder if this individual. I suspect there's obviously some kind of mental illness with this individual. The Lester. I don't want to mess up his name, but the ICU PA, he shared, some things with him and, Lester. So for Diogenes Archangel Ortiz, that was his name. At one point he said to one of these nurses, the shooter. Yep. At one point he said,
Diogenes Angel Ortiz.
Correct.
And you're wondering why this isn't in the news.
Right. Well, yeah.
It's because much of the news doesn't want to feed into the idea that someone with a name of that heritage is holding people hostage in hospitals.
Correct. Yep.
Fascinating.
Yep.
Okay.
Wait. Yeah.
No, I that's hilarious in a real messed up way, because in one of the first paragraphs you went into as we began speaking was about how I can't believe how the press isn't covering this.
Mm-hmm.
The way you said that immediately made me assume must be a white guy and they're not talking about it. Like, why wouldn't they be wouldn't they be talking? So the fact that you were surprised made me think it was a white guy.
Yeah.
Or someone who fits the stereotype that like The View would love to go bananas on.
Right.
Kind of thing. Like, it's a preposterous conversation to people who listen to, for example, legal podcasts versus people who ever spend 30 seconds watching TV. It's like the version you get through the TV, boy, are they really insulting your intelligence as a viewer. Like if you knew how bad they were insulting your intelligence down the line, I mean.
Yeah, absolutely.
Rittenhouse, Johnny Depp, you name a trial whatever's portrayed as the headline,
Right.
I bet you $10 what's going on in the courtroom is
Yeah. Oh, I'm sure.
it's always
I'm sure what you see.
amazing, like mass media versus legal blogs, legal podcasts. It's night and day. And forgive me, but okay, well, that explains why, for example, CNN, MSNBC, ABC, CBS are not out there screaming under the political circumstances.
Correct.
And if you're watching this in 2052 and you're wondering what we're talking about, Donald Trump just got elected president, and there's a lot of people who think he wants to, get rid of every immigrant. He doesn't like immigrants, but really it's a focus on illegal immigrants. But the conversation has gotten super muddled in the mass media and become just stupid. And the last thing that I would expect to see is in the middle of that for them to take a situation that, to your point, holy cow, would this be national news if a couple other characteristics were part of and that's just so bizarre, but a real trend that's I have no compunction to put that on record. It's prima facie. It's like plain as day.
Right.
Okay. Well, then it's not gonna be in the news next week either, Matt. Let me just FYI.
Right. Yeah. Yeah.
But it's make sure I do get a package of all the links and the GoFundMe's. I'll make sure we accompany that with the story. So a little bit about your background. Where did it start, and how did you evolve to this particular niche in protective services and security?
Yeah, never set out to work in healthcare, police, and security ever. September 11th I had always had an interest in the military. September 11th was my senior year of high school. Spent all senior year reading up on Army Special Forces teams, and I said that's what I'm doing. And got out, enlisted, served in an airborne infantry platoon out of Alaska. It was amazing, great experience. Made a deployment to Afghanistan there, and went on to a Special Forces team. Was selected, went through the Q course, and interestingly enough, they retrain you in there. Like, it's not just enough that you can pull a trigger. Now you have to contribute something meaningful to your team. So there's 4 different specialties, and I do think this is big. Is for my development was I drew the medic card. There's 4 different jobs: weapons, demo, engineering, communications, and medicine. And so spent a year learning medicine. I was in trauma centers. Multiple rotations. I was in El Paso, level 1 trauma center, in Florida, Tampa General. Long story short, I get out and was looking to transition into law enforcement. I had an uncle who was very influential in my development. Moved into law enforcement, but at the time, by this point, I'm a little bit older than everybody out. I'm getting out right in the recession, 2008, 2009 recession, and first place that would hire me was a healthcare based police department, and later left, went to like a road based police department, but came back, and just since being back, for one, it's been great for my family, but 2, just been involved in different niches or roles in it. And one of the things that my wife's a nurse, and I've known her since high school, long before the nursing days, but when we were in the Army in North Carolina, she had a patient, I don't know what this would have been, 2005, 2006 timeframe, that tried to choke her with her stethoscope, and this was like kind of putting it on my radar of like, hey, this is the level of violence in healthcare is pretty crazy. And so, I ended up coming back to healthcare based police department, and I've been here ever since. And one of the areas I really hone in on is trying to help prevent and then respond if you have an active shooter. And so involved with training, both within police and within healthcare bedside staff.
Circling way back.
Yeah.
In terms of what protection is at that level now. So we're back in hospitals. What does it look like in terms of get the sort of middle of the, pick a state, give me an example of somebody who's doing it right within the constraints of the bureaucracy in which they operate?
I do think the facilities that are prioritizing it with they're effective with their funds. They do have the margins to where they can invest in this. I do think it's no one thing, right? Like it's weapons detection.
It couldn't be, no.
Right? Isn't
going to
solve
there's
it.
Too many moving parts, and it's too technical. okay, if the listeners like, I don't know, you put a couple cops in around the place, or, make sure somebody drives by every 10 minutes. So if there's a response, they're always within 5 kind of thing. But okay, so then that involves them in a perfect world. At every entrance point of the hospital, the cops then also have some sort of access port that they have a key for, that they have a fob for, that opens up and gives them an access key to every door in the hospital that doesn't exist right now. That's not a thing if it exists, it's not in general application, or if it exists in some other form, it's not in general application. But just as an example, what you don't have today, even if you have a bunch of cops, you could have a Dunkin' Donuts on one corner, right? And a Krispy Kreme on
real
the
now.
other.
Yeah.
Okay.
Yep.
You're still not going to have the ability for cops to be in every point of the hospital, even if they're wall to wall in Krispy Kreme and Dunkin' Donuts across the street, because they're going to get to the hospital, they're going to get 50 feet in the door, and they're going to hit a hard spot. So if they didn't have think a realtor key box outside, that's got maybe 15 units per doorway, where the first 15 cops through that door all have access to grab a fob, and boom, they have access to every room in the hospital. That is perhaps preposterous and asinine. I don't know enough about what I'm talking about, but to give the listener an idea,
you're correct.
That's one of probably 10 things we can come up with that isn't systemized and in alignment, both within the hospital infrastructure as well as the local county, state law enforcement routine.
Getting them familiar with the campus. And then also, just from a practical, most your workplace violence is from the patients, right? And it can be agitated patients. It can be patients with dementia. It can be mental illness. I mean, there's a huge range.
It could be patients who were completely just whacked out.
Yes.
On coming out of an anesthesia not in the right mind, freaking out, I would imagine.
So hiring effective people who can actually talk to other human beings, right? Who aren't there that need to slap cuffs on every little thing, but are willing to be around and present. I think if nurses feel comfortable calling you, maybe they just have to go in the room and do a procedure. Maybe they just have to go in and draw blood. I think the biggest thing people can do is prioritize it off of your personnel, that you hire people to where they don't mind coming in and just standing at bedside, shooting it talking with the patient. They draw the blood and you leave, and so first and foremost, it's good people, but it's to get good people. It's hard to get people in law enforcement. It's hard to get people in security right now. It's hard to get people everywhere. But I do think prioritizing good people and paying them well is huge, because those are the officers who they're involved. They're talking to patients. They're up on the floors. They're in the ICUs. They're invested because, like you said, and like I said at the start, it's a highly access controlled environment. So it could be very challenging to get police up when you're, if this is up on the 4th, 5th floor, right, whatever, one of these ICUs, all your security responds up immediately, as they should, right? How are those officers finding, 5,900 or whatever unit that is, right? So yeah, I think, but a lot of the violence right now is simply from patients, and so having good staff who are there, present, around, accessible, can talk to human beings, is that's square one, in my opinion, before any equipment or technology.
Yeah, I mean, and you would think that would also facilitate a great deal of deterrence in that if people are trained, they're going to recognize issues in advance. They're going to recognize an issue that qualifies as needing to be addressed before it's something that it becomes a mention in the quarterly report and drives your insurance cost up or something like that. So staff, you're talking about just training all the nurses and everything. And so that's what your role is. And so your role, are you an employee of the hospital system? Correct. Are you an outside consultant? I know you have your own business.
Yes.
But what is?
So my day job is a campus supervisor, for a healthcare based police department. And so having good staff, like trained security or police, I don't think it matters that much. I think good security can do a phenomenal job as well, right? It's more about the right people. In times it helps. There at times you're just a rent a cop, right? You know what I mean? There are some people who aren't leaving unless you rarely, but there are some people, they're just not leaving unless you put cuffs on, unfortunately, and you go that route. But yes, I am police within a healthcare system. And so, I think it starts with that. It starts with well-trained, good people. And it takes a special type of officer, because if you think about it, most of these states, you guys are working through this in Florida. I was reading about the 67-year-old who was, assaulted by the individual who was brought to a facility. Is it Baker Act in Florida? Is that right? What you guys have for?
That rings a bell. And for the listener who's listening to the New Jersey Criminal Podcast, Florida comes up because I'm recording from Florida right now.
Yeah, right. So each state has some way to, if someone is suffering from mental illness, if they're either suicidal, homicidal, failing to take care of themselves, most states have provision where a doctor, a psychiatrist, a police officer can do what's called a civil commitment, where they seize you and they bring you to a facility for a set time frame, and those people are evaluated. And like in Ohio, they can be held for up to 7 business hours. And so, however, though, like, this is America, and people don't like being, told like, hey, you're not free to go, right? And so that creates major confrontation in ERs, especially.
Oh, because you think?
Yeah, and well, so here's one. Guy comes. This happens constantly.
I'm sure that never gets abused, and by that I mean I'm sure that gets abused. Much
Absolutely.
like you would see in the family court system, there are certain, levers that lean, to certain. Well, frankly, to the female. You can just look at the statistics, but there are minefields you can step in, and I'm sure there are for women, but for men especially, it's almost cliche. Some of the pitfalls that you can get walloped with in a court system before you can get it rectified. And I'm sure that this is the kind of thing where a real evil person, would do this to destroy somebody's life.
The ER docs generally have they've kind of accepted they're not going to save the world. Like they've kind of accepted, like, there's a small population I can help and I'm going to help them. But I do notice even more on the inpatient. So, let's say there's a patient brought in, suicidal, right, is going to get admitted to a mental health facility, but has some sort of health condition that must be treated first, right? So these patients are going up to inpatient units, nurses having to take care of them. They maybe even have a 20-year-old nurse's aide sitting in the room with them. This person has a diagnosed mental illness. It doesn't mean they're violent, but some of them, they want to leave, right? And so they're being held there, treated medically until they can go to an inpatient unit. And that's supposed to be, in Ohio, that's supposed to be revisited every 24 hours. Well, some of these docs, like, you see a total mental shift in some of these people where, like, hey, they probably don't need to be here anymore, but we're holding them, right? And so think about how the position this places our nurses in, right? Because there might be 3 of us for a major 300-bed hospital, right? And so we're all over the place.
Wait, 3 nurses, 300 beds?
Well, no,
is that
I mean,
a real
like,
ratio?
No, I mean 3 security guards. 2 or 3 security guards.
Okay.
No,
Yeah. Okay. Big difference. Big difference.
So,
okay.
So we have to leave, right? And so now you have this patient who is suffering from mental illness, needs admitted, probably does need treatment, and yet they're not free to leave until this medical, right? They get so many antibiotics or whatever till the medical side is resolved, because the inpatient facility for mental health doesn't have the capacity to treat them medically. And so, there's a scenario right there where, you see these nurses, like, having to be basically almost like a corrections officer.
It's 2 worlds.
Yeah.
It's a completely, you're jury rigging every situation, because unquestionably within this framework, the situation is imperfect. And so from the perspective of the healthcare professional, it's ripe with, oh, this is going to be one of those days I go home just frazzled and exhausted because this person's sort of in a crazy place. And from that person's perspective, even going back 2 minutes to what you're saying, it's like just the process they're in at the very moment might be causing them to act, in a word, crazier than they've ever acted in their life, to perpetuate the seemingly necessary, appropriate, measured nature of the situation they're in. whereas maybe that person's not a fit at all. In fact, maybe that person's so not a fit. Maybe they are such a straight arrow, early paid taxes, church every Sunday, that this mere condition is putting them in such a state
Correct.
that they're really, really struggling to keep it together.
Yes.
It could be the sheer fact that they are not the person you're looking for that has them behaving in the way that you think is what you're looking for, is the messed up thing. Just to point out a real grotesque, feature of the conversation, I guess, is the only reason I was going down that road.
Yeah. So I think there is a place. We were talking about, making hospitals safer. I do think there are cameras, for example, that can be used more offensively, that, if you trespass somebody, they use AI or different technology to see, like, if this person comes back. One of the instances that just like keeps me up at night is there was a shooting in the Bronx Lebanon hospital in New York, and I've written about it some on my LinkedIn, but this guy was a resident who probably should have never been hired based off of what was in his history. Like, I think his background check there was a huge opportunity where this guy should not have been in medicine. I think there was like sexual harassment type issues with staff. So ultimately he's fired. He tells them, "I will come back and kill you all," and leaves. Now, I don't remember, specifically what was done at that point, but here's what keeps me up.
But his picture wasn't put into a file that now Matt makes sure that anytime he's on not just hospital property, but hospital system property.
Correct.
What the hell are we doing? That's not even a tough implementation because you would think you're doing it at the system level. It's not like you have to build out.
And you could also do this. There's cameras that read license plate that can alert that this vehicle's back, right? And that's where I think the technology comes in, because this dude doesn't come back until 2 years later. And here's the other thing. They know in targeted violence, more often than not, it's some type of grievance that leads to the act, right? So in this instance with UPMC, the grievance was his wife passed away and he felt like they didn't do enough to save her. Well, in his instance, he felt like his firing is what killed his career, but he didn't come back until he was fired from another job 2 years later, and he held them responsible, right? So how do you prevent these right? Like, so there's turnover, right? Like we hire a lot of retired officers who are in that window. They retire at 55, but they can't get Medicare till, 65, right? And we have some phenomenal officers in that window who do great work. And yet it does lead to higher turnover, right? Because some guys are coming into these types of police agencies and they can't wait to get to the road. And that was me, right? Like, I'm just here stopping by and I'm out, right? And then you have other guys at the end of their career. So these types of departments attract agencies, or these agencies we naturally have higher turnover. So and not to mention, it could have just been a day off, right? The guy who knew him, the guys who were aware of this doc, they could have just had new staff in. So that's where I think there is some technology, license plates readers, offensive cameras that can detect weapons using AI, and then they're screened by veterans, right? Like, that's where I think the layered approach, that's weapons detection systems, I think help round out, an excellent, well-trained police or security department. But I do think that, those types of events, that's what really, like, man, how do you prevent this if this dude may not be coming back they make these threats, they may not be coming back for 2 years.
Well, so both examples you gave in the last 10 minutes kind of had what you could consider noteworthy preambles. And
Correct.
So if there were a system in place whereby somebody could say, listen, this guy didn't exactly threaten us, but because we don't exactly have great protection here, maybe we should just keep an eye out, because if he's coming back to visit, it might not be for good reasons. And like I said, it takes just then dropping his ID into a folder.
Yeah.
And by populating that folder with his ID, he becomes part of the system, where then if he steps foot on any hospital system property, or even then maybe hospital systems get together and invest in this together so that they all get a discount on the set implementation, and it's shared across the whole state's hospital systems. Right. And then hell, maybe that's not a hard grant to write. You get the state to kick in for it, for the love of Pete. But it's as it is with AI, I'll tell you what I might make you do is offline jump on another call with me, and just for fun, just to blow your freaking mind, you bring a notepad of the technical solutions that are required. Because you know a soft target, a hard target. Start with a soft target and make the whole list of like, well, you got to have this, and you got to have this, and if police show up, they got to be able to. You make a list of what that is, and what I can tell you is, if you and I spend an hour and a half, I could refine it into a rough requirements for an app.
Correct.
That would be the kind of thing you would sell to the hospital system, and like so, it's as a sort of technologist, I can tell you this. I know system A exists. You know, I know there's a database I can use as a repository. I know system B exists. I know there's security cameras that can be used defensively. I know that there's access control systems. I know that there's mobile app proximity style things where, like when I was saying, when the cops run up to the exit of the entrance of the hospital, maybe it's their personal cell phone. Maybe it's not a key fob in a lockbox or something. Maybe it's their personal cell phone that's been opted into a thing, and they always have to have their Bluetooth on for situations like this. That would be enough to give them full-blown access to every nook and cranny in a hospital. But and there's everything I'm describing is technology that is like just waiting to be put together and into a secure black box platform and sold, you know, by somebody who's got a credible pedigree to sell it, is what it sounds like to me. But it's probably a lot of business fixes in general need to happen, and like fingers crossed, knock on wood kind of thing, that there's a bit of a revolution in healthcare and trying to drive more value to the consumer of healthcare and trying to cut processes and partnerships that don't add value, make things cumbersome, and hopefully I think it'll be a mess for a year or two, but like I'd rather see it be real painful for a year or two and then fix it good than like, oh, we don't want to be disruptive, let's keep tinkering with it for what, 2 more decades? Like, I don't know about that. I think like break it and fix it is almost, it's plus from a technology perspective and like a management perspective, it's so much easier to build something than it is to change something. For sure.
Absolutely.
What we haven't mentioned it, but it seems like an obvious evolution of the conversation. What about some percentage of healthcare professionals carrying a certification where they've been to freaking jujitsu, knife fighting, gun training, all that stuff, just, you know, some criteria that are all recognized as, oh, this is a dangerous person if they have to be. And that person makes probably $8,000 more a year than their counterparts and is worth every freaking penny, because all of a sudden for an extra $250,000 a year, you can have a lot of floors actively upgraded with a BMF who can handle the business.
There's a lot of, it's shocking, but like a lot of these nurses, you know, they have, some of them, you know, are great, but you know, a lot of them have very, very little situational awareness, even entering a room. And, you know, I'll give a shout out to Mel Cortez from TACBook. You know, we can try and link her in, but you know, she has some great situational training for nurses where like literally just helping them from the room. Like the nurses don't think this, right? Like they have so much meds to pass at this time, and they have 4, 5, 6 patients sometimes, and they're trying to hit those, right? There's hard lines, and they're the only ones who can pass these meds. Their aides can't do that. So they're rushing into a room, and they're getting on the far side of the bed, you know, right? Because that's where the IV port is.
And they're doing math, and they're reading little tiny labels, and they're checking and double checking and triple checking, because the real danger at hand for them at that moment is distributing the wrong information. and hurting somebody directly or distributing the wrong, prescription. So what they're doing in that moment is a very concentration intense. So it's just for the listener who thinks they're just dropping off pills, they're making a list and checking it twice like they were Santa Claus, because the downside reaches criminalization if they make a mistake. A mistake for a nurse can be criminal charges. So if you think they're running around just, like the paper boy zipping past the room and slinging some pills in there, it's a very concentration intense practice to go room to room just delivering medication or just hooking up IVs, because it's just the back and forth from clipboard or from tablet to label to tablet to label, and scanning and checking and scanning and checking. They probably didn't check the corner of the room to see if there's a boogeyman back there.
Right. Or they're on, what I would call like the Medal of Honor side of the bed, right? Like they're on the far side of the bed where, right, like there is no way out if this dude hops up, right? But they're just, like you said, they're trying to pass meds. They're trying to not kill anyone. They're trying to make sure there's not any mistakes. And the level of complexity of some of these IV bags, this one has to be in this bag has to be higher than that one. Nurses don't get enough credit, man. And then they're quarterbacking the whole thing, right? Like imaging's asking, can they come get this guy for that procedure, right? They have lab, like, we glorify docs, and I mean, they're brilliant. I'll give it to them. But man, like the quarterback is the nurse, right? Like they're keeping it all moving. And so, so for them to, get to on the wrong side of the bed, and this guy's been fine yesterday, right? No issues. And then boom, that's it. Snaps. Right. And now all of a sudden they can't get out. So and then that's where like there's also, we started to go down technology, there's wearable devices that can, designate like, hey, this is, and some of them have two buttons, right? Like one is like, hey, you guys could start my way. I could use some help, start me security. And then the other's like, oh crap, right? Like this is major issue. Like they're simple devices there that we can start to, and the cool thing about those is they're not saying anything. They're not saying like, hey, I train my staff just to say like, my primary hospital is like a smaller, a little more of a family feel to it, smaller bed facility. And I train them just to get on the radio and be like, hey, can Matt come by and give me a hand? Right. Even if I'm not the one working, right? Like they know the day shift crew knows me. Right. So subtle ways to get that in. But I think that's where like people like Mel and training these nurses, they have no perception or awareness of like the room and like, hey, when is it safe for me to be there? Right. Like, what do I look for? What are those, what's an indication that this person might be headed towards violence? Where am I safe to be? Can I get another nurse just to watch his hands, or an aide to come in and watch their hands to at least alert me while I do this complex procedure? And that would be step one before the BJJ route,
Well, or even I keep going back to, we're definitely discussing a specific class of patient that is existing right now in some sort of limbo purgatory situation that's completely inappropriate for them and completely inappropriate for the staff who's managing them. That is healthcare staff, when the subject and the situation itself is a hybrid of, what would the word be, of potential combustible.
Yep.
It's a potential combustible healthcare, mental health / criminal law stew.
All the data supports. Go ahead.
And that person is sitting in the middle of 1, 2, 3 normal patients to the left, 1, 2 normal patients to the right. Yep. Then there's another dude who might be a freaking firecracker. And then there's a bunch of normal patients. So it seems to like this whole conversation I've been picturing just like, boy, wouldn't it be nice if in every county there was just sort of a middle-sized facility that was designed for this class of people? Because then you wouldn't necessarily have to have this heightened tension in the hospital 24/7. And, basically what I'm saying is, expand or specialize. I'm not saying expand. I'm saying specialize. If there's a real number of these people, if you accommodate them in a specialized way, it's not super difficult, because what's difficult to do is to manage situations that come up 1 out of every 7 or 1 out of every 9. That's very inefficient to switch from mode A to mode B midstream of your workflow process that might or might not require you to involve other human resources and or resources in general, even technology, as opposed to you're doing 2 jobs at that point, and you're requiring 2 tool sets and 2 support systems. And so all I'm saying is you might find more if you're that. If this hospital system A is owned by a hedge fund, maybe there's math to be done there that says, you know how much money we save by breaking off a specialized, like what would be the equivalent of one hallway on our current hospital that was dedicated to this class of hybrid patient slash suspect slash mental patient slash emotion, potentially.
And there's nurses who thrive on these types of patients,
person who's
right?
just
So
an emotional
there's patients who are
this is
who
the most
excel
they've ever been
in this
exposed to
setting
in their life,
and would be willing to do that. There are nurses who will thrive in this environment. There are nurses who love the behavioral health side of it, right? And they would do that. And these are the nurses who are much more naturally inclined towards situational awareness and knowing when to ask for help and not. And I know
and when
there's
that's part of your regular workflow, it's so much less energy and angst expended if your workflow is what you expect it to be, and it's not bouncing between these 2 sets of patient types that really require you to do 2 different roles, probably potentially requires different technologies, different support staff, different conversations. And so to jump back and forth between those is really inefficient. So that's what I was getting at, was like maybe a hedge fund guy who owns a hospital system looks at that and says, if we had just a hallway worth of building with these specialized nurses who, if that's just their job, like I said, we're not throwing them curveballs, that's just their job, that becomes a much more efficient solution. And so all of a sudden, these nurses over here are far more productive, far more healthy, like far less exhausted, far maybe less turnover even at the end of the day because of the stress level of a nurse. What does this hybrid class of patient, what do they contribute to the pie of just stress? Does this fraction of patients contribute 80% of your stress? I'd throw money that for some nurses it's in that neighborhood, maybe more.
Absolutely. And one thing where I don't want to paint an inaccurate picture is the other side of this is these aren't all patients on a hold for mental illness. The level of entitlement, right? We became, healthcare is a business, right? And in every hospital, right, you can pick which service or which company you want to go with. And so as such, scores became the holy grail. And so our nurses serve them now. And, what would you like to eat? And can I get you coffee? And, there's all these other elements to where, like, I think we've promoted these people who are just like so entitled and so pompous and arrogant and just so demanding of our nurses. And these are people, maybe these are, I mean, it can be anything from, it sounds like I'm describing like wealthy, affluent. I'm not. I'm describing like very needy people who are just not healthy. So they're in and out of the hospitals, left and right. They're not following through with their antibiotics when they leave or whatever it is. And so they're back again, or maybe they're IV drug users. And man, like the way they talk to nurses, like the hardest part of my job is checking my tongue when I see these like extremely entitled people. My wife used to say to me, like when our kids were little, she'd be like, Matt, babies need insurance, right? Like, don't rattle off the cuff and say to these people, potentially what you want to say. But there's just this level of entitlement. And I know we're getting into much bigger issues now, but I say that to say, like, these nurses might go from an old guy with dementia to a highly entitled IV drug user.
Well, it's a precursor. It's worth mentioning because it's a precursor to the types of incidents that we're saying puts people into a certain class of patients that draws so much energy and angst. Like entitlement or anything that you're creating friction, you're mistreating staff, you're being difficult in that process, and you're doing it in a way that's not in good faith. Like I can see being difficult if in your heart you think a loved one's being underserved or you're being underserved or they're not listening to you. Like that's all fair. But if it's like what you're describing, it's an entirely different thing that leads to conflict, that leads to the potential where you now have a patient who's creating a different service type, a different workload, a different anxiety level, and a different support requirement. And so it's from a business perspective in that sense, to avoid it in any way is brilliant, and to address somehow even the socialization within a emergency room waiting room. Like, I'm sure you could hire a bunch of your clinical psychologists who could have an amazing conversation about how a hospital emergency room is, just how it's set up, and how things are. It's almost a hospitality conversation. It's almost like when you walk into a crowded establishment, bartender can't possibly get to you. There's no chance. But he makes eye contact with you, or she makes eye contact with you and says, I know you're alive. Clearly you see the situation I'm in. There's not a possibility you're going to hear from me in 10 minutes, but you're on the list now. That gets in front of everything. If there's a way you can, and I say that is a hospitality tactic. But as somebody walks into an emergency room or begins communicating with emergency room staff, if there's a way to disarm them, it's worth doing for your own good, for your own downstream workflow, for your own downstream human resource requirements associated with each patient type. If you can disarm this person, if you can be the bartender who makes eye contact with them and says, we're here to help. We're not perfect, as you can see, because if we were perfect, you wouldn't even be waiting. But boy, there's ways to get ahead of, and in your field, it would be called I keep calling it hospitality. It's de-escalation. It's a preemptive environmental buffer to not create a situation where you then have to use step 2 de-escalation, interfacing, conversation, choreography, maybe to make sure you're in between somebody and something else. Like, all of that is de-escalation step 2, as far as I'm concerned. You can, by the very environment you create and the very dialogue you initiate, de-escalate potential situations. And I'm sure that's not top of mind based on how many other things they have pulling at them. But again, in a perfect world,
it's a simple example. We're coming out of one of the worst flu seasons in 15 years, and hands down the busiest I've seen ERs in about 10 years of working in healthcare-based police departments. And one of the ways they kept everything moving is they literally just planted beds in halls. They call them hall beds, and they could get them back, could draw your blood, could shoot a chest X-ray, could run some tests, and there were patients who were clearing ERs within, an hour that otherwise they'd been waiting for who knows how long. And the interesting thing was the more experienced nurses were so much better at, selling that, of just saying like, hey, you know what? So we can get everything started. We're going to get you back to a bed. And, some of them, if they were truly sick, they then got moved into a full side bed. But if they weren't, boom, they're out the door. And, how those patients, it was interesting to watch how those patients perceived those off of just how the nurse sold it to them, and just how the nurse presented it. And it was true. I mean, it really was to get them out and keep them from having to sit in our ER with a bunch of legitimately sick people. And so, and we can do, that's what you're saying, is we can do the same thing, whether it's mental health, all these things, like how we talk to nurses, or how staff talk to patients, from security to nursing to lab, to all of it. It makes such an impact. It really does.
There's a great tool, and I use it. I recommend it to podcast hosts, but it's also just an incredible tool for conversation and for sure de-escalation. And there's this former FBI hostage negotiator. You've probably seen him. He has a big media presence, Chris Voss. And so I subscribed to the Masterclass app and went through his Masterclass presentations. And there's a few in there that are just unbelievable for, one's like mirroring, and not like you sit like they do it, but it's if somebody's letting it out, maybe an angry, frustrated person, they're letting it out. They're letting it out. And the last thing they said was, and you guys keep changing the prices stuff. I get a bill later and it's always a disaster. Mirroring would be for then, maybe the billing person at the front desk to say, it's always a disaster?
Right.
What else is she going to do at that point to solve the problem? So she
Right.
simply takes the very last thought and says, it's always a disaster. What does that do?
That's good.
Right back on you, sir. You seem upset.
Yep.
What have you got? What have you got?
Clarify.
What have you got?
Yep.
And it's also, I use it as, I think it's a great host technique. So it's like, if somebody's talking about something they're passionate about, just take the last thing they said and, back to them. Like,
that's good.
When you were, military, that you took the medical track. Interesting. And then just hope you talk for 10 more minutes at that point.
Right.
But it just occurred to me that if you took the 2 or 3 sections of that negotiations course on masterclass, it would probably total about 20 minutes, the 3 sections that I think are totally applicable. And like just something like that. Yeah. In the holster of someone who has to deal with people who might be teetering on the edge of falling into this difficult, combustible patient class. Like, well said. That's legit 20 to 24 minutes. And it's things like that because I'm like you mentioned before, you're quick to like call out BS, or it's hard to hold your tongue. I'm the same way. Like, but I also I produce podcasts. I do stand-up comedy. I'm not a lawyer. I don't have to hold my tongue. That's that's my client's problem. Yeah. Yeah. Right. I'm allowed to come on a podcast and say preposterous things. I don't even have a Juris Doctorate. So it's, but those tools are very effective when you want to have a super productive conversation in terms of drawing out information, in terms of letting the other person feel heard to the point where they almost realize they're arguing with air. They're not really making a point. They are letting it out. And so it's sometimes you doing that can be enough to depressurize that which would later combust. Kind of thing. But it's a many layered cake you got to bake in terms of this. I mean, you're talking about from sociology to technology, the way to manage, because heck, if hospitality operations have to think this way, for darn sure places with a security concern are going to have to think about everything from the sociology to the technology if you want to fully address the issue you're bringing to the table. And I would proffer, this gets worse before it gets better.
I agree.
I've never in my life had more disgust coming out of the COVID situation. Like, the people I would find fault with aren't the kind of people I'm even going to meet in a hospital, by the way, when I'm getting treatment.
Right.
But you can't tell people the sky is green for 3 years.
Yeah.
The downstream,
and I think a lot of them don't realize the level of mistrust. I try and paint that picture for staff, and like less than a mile from the hospital I work at in small town USA, there was a Luigi flag flying from Mario Brothers, and I took a picture and I was sharing it with our staff. I said, that movie came out in 2023. It's a brand new flag. They aren't the major Super Mario Brother fans, right? These are people who don't trust you. They don't like you. They don't respect you, right? And what's unfortunate is the nurse at the bedside is just trying to do her job, but because of decisions at much, much higher levels, that is like overlaid on them. And I have to try and help them understand, it's hard, but you've gone into a profession where there's a lot of people who don't respect you anymore. And, they'd rather talk to like their chiropractor or their, whatever. And that's where we're at. And so, just trying to help them understand, unfortunately, you don't have the same clout, and we kind of got to regain some respect.
For me personally, so I've thought a lot about it. And for me, here's what I know is now if I go to a doctor, I don't know. If I'm in an emergency room, I don't know. Who are the dirty cops in here? Because my issue is there were people actively doing harm to people by following what was the CDC narrative, for example. And without going into conspiracy theories and relying strictly on things that are now like congressional data. We had the worst outcome of any civilized country and
Yeah.
spent more money than any civilized country. So
Yeah.
I don't, anymore, I'm no longer hesitant to share my opinion. Even though this conversation, for example, this clip would have gotten me literally a lifetime ban from LinkedIn 3 years ago. If I put the clip up where I said what I'm saying now, which is that the CDC made mistakes from start to finish, and we had the worst outcome of any civilized nation, that would have got me thrown off. It did. I got banned from LinkedIn permanently and could only rejoin on a new computer through a VPN because I said, I beat COVID in 2 days with a leave. Can we open the country back up?
Right.
That was my post. I got a lifetime ban from a company that Bill Gates has an interest in shortly before he sold his vaccine stocks, and later said, it was really just heavy people and old people. We misread the situation. But that was the climate. And so I had an appointment to get vaccinated for COVID. This is after they changed the definition of vaccine, which a lot of people are unaware even took place in 2021. But I was going to get the vaccine. They actually talked me out of it. Like they started giving away cheeseburgers if you get vaccinated.
Yeah.
They started calling you racist if you weren't vaccinated. And I was like, well, that doesn't sound like the strongest argument. And so they unsold me on the vaccine. It wasn't that I started out like, I'm not listening to any. It was, why are they giving away cheeseburgers? Why did they change the definition of vaccine and remove the word immunity? Like, and why do people call me crazy when I point that out? Like, look it up. So you change the definition of vaccine while you're trying to sell me a vaccine. That's the one time you're going to get me asking questions about a vaccine. So my issue back to the bad cops is it's seemed awful quiet in the room. And I'm no genius. I'm no biology major. See, I can't pronounce it. That's how dumb I am. And I know that natural immunity works. I know that natural immunity isn't racist. Like the stuff they were saying about like it just didn't match up. And so I'm sure there were lots of good healthcare professionals raising their hands saying this is preposterous. I did not come across, and if they did, I think they were probably fired. Those people are saints. The people in the military who got fired, saints. Like that's critical thought. And even if they had been wrong, respect to you for having what it takes to stand up in the face of the most expensive propaganda campaign ever funded by taxpayer dollars. So,
well, and going back to what we talked about, I
always have to look around, and I almost want to poll them. How many of you vaccinated a healthy person under 12 years of age during COVID? How many of you, thought people who weren't vaccinated shouldn't be able to go into a restaurant or a gym or, like those are the questions I have for my doctor, because that to me is the new litmus test of, is this person capable of critical thought, or is this person literally going to do whatever their Pfizer rep tells them to do, like a good little boy?
And I have to wonder if our flu numbers right now are, in relation to all, us not being out, us not, immune system not having to work, right? And the rebound of that,
I don't think that's a even complicated math, what you're proposing. And it's old news in other countries. We're the last company to critically examine COVID. We're the last country to do studies or even allow or fund studies. Like Denmark's been funding COVID safety studies and having the real conversations since like 2021. The United States, where 80% of television is funded with pharmaceutical money, wasn't having that conversation. So that distrust, what a waste. Like it's just a pure waste that I now have to go in there and spend time polling your staff before I can decide if you're going to be my primary care doctor. I want to know if you're an idiot or not.
Right.
Or I want to know if you're a quisling.
Yep.
Or that's essentially, those are the Jews who worked with the Nazis. Because to me, if you're a healthcare provider and you're taking your orders from people who say natural immunity doesn't work, you're a bad cop. So I eat a lot of garlic now.
Right.
I hear it's it's antimicrobial. I just try not to get sick so I don't have to interview anybody. But that's more time than I needed to put into. But I mean, again, I was trying to have a conversation 2 years ago and getting kicked off a platform. So forgive me 10 minutes now of digging into it, because that all happened. But I don't think it's hard to regain people's trust. I really don't. Because as long as you face, there'll be challenges. If you face the next challenge with some transparency, you don't yell at people who want to do math instead of talk about big numbers. Like that was the other thing during COVID. 1 million this, 500,000 that. Yeah, but if you do long division by how many people are in the country.
Right.
And that's there was a hashtag for a few months, math is racist during COVID. And I think that had to do with it. It's like, all of a sudden math is racist too. But it was because you weren't allowed to talk math. You had to talk big, grotesque numbers during COVID. And again, one challenge doesn't have to be some big thing, but if whoever's in charge is just honest with us and transparent, I think I'd be right back on board. Like, you know what? The tracks are back in the right direction. I don't think it's got to be some horrible thing because you have to interact with healthcare on the daily. So if it just kind of gets more honest and more transparent from pricing and onward, I bet people would be less pissed off. I bet people are less pissed off.
No, I think you're right.
Fewer of them show up 2 years later with a handgun, a duffel bag full of zip ties from the inside or from the outside. Disgruntled patient or former employee, because that employee, half their disgruntled nature probably comes from patients who are disgruntled just rubbing off on them. Like that friction.
Yeah, and there's a whole field of this now that's starting to get more and more involved in healthcare in behavioral threat assessments, where there's different science-based tools that are they're using. It ultimately comes out of the FBI's behavioral analysis unit, and there's different organization, Association of Threat Assessment Professionals. There's certifications people are getting, and I just had a great conversation yesterday with Mark Concordia from Atrium Health, and I think they should start following guys like him, where he's essentially career law enforcement and has been building out tools in healthcare for assessing these types of people, because there's both the threat assessment side and the threat management. The threat assessment is like, what's this person's propensity towards targeted violence afterwards. Do they have the ability to do it? May they do that? And then there's the threat management side of like checking back in on these people. And so you alluded to that, like the sociological side as well, but there's this also psychological side that's advancing rapidly with just super practical tools that can be put in place. And so I think that will be even higher end, right? Like we talked about good police, we talked about good technology. I think we're even going to get into these threat assessment teams getting broader and broader, roped into healthcare, where that will be the future of workplace violence, 10 years from now or whatever it may be. What's the coolest technology you've seen that you think is just a killer application that everybody should have in a perfect world? It gets knocked, but I still think just some of these newer weapon screening tools that can get a crowd into a stadium rapidly and assess these people for weapons. I mean, it's stuff. The game, you're on this continuum of, if it's going off too much, right? Like then the person scanning has to get in there and get their hands dirty, right? So if you make it too sensitive, then there's kind of like a fatigue, right? Like there's fatigue on your staff and what you can afford to pay these types of people. But I still think there's a place for it. Just like plain and simple at some of these entrances, whether that's like a more incognito tool to alert to like, hey, there's possibly a weapon here, to where security can hunt this person down and follow up with them. But just some type of weapon detection. I still think there's just a basic place for it. And, we would be much better off in some of these facilities because there's also people who just walk in and see it and they're like, they go back to their car, right? And they leave it.
Oh, sure.
Perfect.
You could probably put one up, not even plug it in, and it would do some percentage of your work for you for sure, 100%. Like putting a cop car an empty cop car on the median of the highway.
Yep. Yeah. I mean, I think low hanging fruit at this point would be welcomed by most working in healthcare, security. So.
Okay, well, there's our first product idea. I'm going to design a fake weapon detection system and just be like, listen, everybody who doesn't have a big budget should have one of these right away. Yep. This is your cop car on the median.
Right.
Yeah,
unmanned. Yep. It would help. It truly would.
Yeah, it's somewhat of clearly it's not an upbeat topic, but with the state of technology, it does become a fascinating and, sort of boundless conversation in what you can apply these days creatively. And I'm sure you're sort of in the nooks and crannies of that market well enough to know that there's opportunities that I haven't even thought of in terms of how people get processed or work through a hospital that create opportunities for identification or scanning or screening, especially if they're making their way in towards sensitive areas or areas where there are people who are in a state where they can't defend themselves. That's another thing is like you've got a class of people in that building where, if you've got whatever the count is, there's X amount of people in that building who literally can't do so much as raise their hands to keep you from harming them. Right. And that alone, regardless of what the propensity is for conflict, disgruntled employees or disgruntled family members, that alone to me warrants a heightened level of protection. If you've got someone who isn't capable in any way, shape, or form of defending themselves, you are 100% obligated to make sure that person has an appropriate level of protection from that becoming a conversation.
And and there's even simple things. We talk about in response to active shooter courses with nurses, right? Those hospital beds are heavy, right? If nothing else, if we have a patient we can't get out, can't get to safety, can an aide stay in there with her or a family member push the bed in front of the door and put the brake down, right? These people who are active shooters, right? Like they probably have somebody they're specifically targeting first. And then after that, they're just going for a body count. And if that's them, right, if there's any resistance, they're probably just moving on because it's a numbers game and they know how they have limited time. So that's one of the things I teach staff. Like if there's a patient who we can't get out, we can't move, can you are you able to move her bed? And some of them they can't, right? Like some of them are so complex that that might be on the scope. But a lot of like your just traditional med surg, doors open in and beds can go in front of doors and you can put the brake down, right? Like right there, we've saved that patient's life. So I still think there's some low hanging fruit where there's part of our industry in police and security and healthcare where I think they're over reliant on technology, or they just want to like complain that they don't have certain technology, right? What could you be doing to like train your staff? And I think back to my military days, right? Like I got to a special forces team, like we had all kinds of cool tools, but man, you should have seen what I had in training. You know what I mean? Like a map, a compass, like some bubble gum, you know what I mean? Like, and that was about it, right? Like there's no GPS, right? But that formed you in a different way, right? Like that sets you up to where like, hey man, if nothing else, I have a map and compass, I can get to where I need to go, right? And so I do think some of the industry's hung up right now, like overly reliant and healthcare and in technology. And one of the things I wrote was like, hey, this is somewhat like you're reconstructing the plane in flight, right? Like, so the plane's already flying, you got to rebuild it in mode. And so, yeah, every year make specific targeted asks based on a risk assessment and not just some cool sales rep. Like, right? Like you looked at the whole picture, you did a risk assessment or paid someone who's better than you to do it. And then, from that risk assessment, you prioritize the top 2 or 3 things. Ask for that each year in your budget cycles, build a good case. Don't go in there with too much hate in your heart, like a lot of us struggle with. And then spend the rest of the year training your staff, right? Like a lot can be alleviated just by training, some situational awareness. Don't be afraid to call us, get your guys out there rounding. Like it's probably not as complex as we're making it. And like you said, within a few years, just like healthcare can probably get some of their trust back. I think police and security can gain credibility, gain trust with these admins who maybe right now can't afford to give what we think we need, right? But can you continue to make those asks And over time, like, I think a lot of us are seeing improvements in the places we're working.
Man, I'd love to see nurses and doctors be able to get some kind of certification and just be peppered through the building with, concealed carry until they've hit a 10-hour shift and they got to put their gun in the locker or something like that. You're not pulling after on an 18-hour shift.
Yeah.
But within reason. And I think the only thing I can come up with would be hours. I think you might have an argument with perhaps even in a civil case if somebody who's been on the job more than 10 or 12 hours does anything. So I think, but even just talking about it brings up considerations like that are absolutely need to be discussed because they're situationally, there's not a lot of industries where you put people on crazy shifts in big blocks like that. So, it's actually funny that that's one of the first things I think of was, it'd be great if doctors and nurses could get certified and could make that section of the hospital is pretty well hardened because, we got Susie at days and Bob at nights and, Guillermo's mornings, whatever. And all three of them are certified XYZ. That's neat. But again, not if Guillermo's been working 16 hours. Guillermo needs to put his gun in his locker at that point.
I think checking out some of, there's a reason they ground pilots at 14 hours.
That's what I was thinking, actually.
Yep. But I think some of Mel Cortez's stuff from TAC Book would be a great place that's simple and cost effective for a lot of people to start. And it starts just with like square one situational awareness and, grows and adds a lot from there. That would be, huge for a lot of staff. And I think we need to start integrating some of that into these nursing schools. Like, these kids come out and they just have I don't know if they really realize what they're walking into. I think we're doing them a disservice to not train them on this element as well, before they're on rotation, that like, hey, we have them thinking of, where am I in the room? Can I get away? We have dedicated behavioral health rooms where I have to like repeatedly remind staff, they have these computers that's like a workstation on wheels. They call it a WOW. Kind of funny. They will back themselves into behavioral health rooms so they can type as they give their meds. And this WOW is blocking their egress from the room, right? And this patient, you know what? I get that vibe. They're probably not a threat too, but you're still repping it out when all you have to do is flip this thing around, and now it becomes a barrier between the two of you. Now it's aiding your safety. And so a lot of low-hanging fruit from just some basic situational awareness that I'd love to see in nursing schools.
If situational awareness was constant, you could avoid 80% of the technology investment that you and I are talking about, because you're certainly correct. That's I don't know. I don't know if it's generational, but because I'm not law enforcement, but I don't go to the mall in slip-on shoes.
Right.
Because if there's an issue,
right,
I'm going to lose a shoe and I'm not going to be able to run. And I'm not going to be able to run defensively or offensively. It's in a restaurant, I'm looking at exits. I'm looking at people. I want to know if there's going to be a problem before I'll be the first person from my friends to be like, what are you talking about?
Right.
This is fine. Let's just stay here. And I'll be the one like, no, I think there's about 1 in a 100 chance something bad going to happen here tonight. And 1 in 100 is enough for me.
Yep.
1 in 100 is straight up enough for me. But they can't argue with that, because it probably is 1 in 100. And if that's my line, that's my line. But I'm like, now looking around, if you can't read, and I suppose I'm just, I don't know. I suppose I feel like if anybody wants to, they can read a room. Maybe there's people who can look at everything around and really not take anything away. But I'm very concerned about things I can't control in an environment that isn't an environment of my own.
It goes back to what you just brought up very well, like the level of complexity of what they're doing, the meds they're slinging. They're doing math, they're checking the 5 rights, all these different things. And it's as simple as slowing them down and helping them read the room becomes step one in reducing some of this.
You
But
gotta
yeah,
give them some cool acronyms or something. Cool acronyms and a checklist, bro.
Yep, done.
We'll put that on a PDF. We'll sell that to other hospital systems for
That's right.
$19.95 a copy.
Yeah, yep.
I'm sure you're right. Like we spent the vast majority of this conversation talking about, oh, you could install this and you could build that. And really, if you were able to give them the luxury of dotting the I's and crossing the T's as they go about their workflow, you probably wouldn't need to do much of that at all.
I'm for all that technology, right? We talked about situations where, you have people on different shifts, you have people coming back at different times. I'm for all that. I think where my profession could be better is when, I think we need to be each year very articulately, I can't even say the word, but making targeted asks for these upgrades, right? I mean, I think it's important. I think we should. I mean, I think they round out the system. Where I see us like missing a lot of low hanging fruit is just that training with staff on all different, I mean, these hospitals get hit with all kinds of, whether it's, power outages and tornadoes, right? Like this stuff's all happening, right? And so, ultimately, like, if you think through in the military, like in basic training, you're working through like 8 different battle drills. I used to have it memorized, like a deliberate task, rapidly executed without applying a deliberate decision-making process. There's something along those lines, right? Where you just, if X happens, you do Y, right? And so, a lot of that happens through repetition, through rehearsals, right? Like when I was in the military, man, the Afghanis hated us. Like they hated the amount of rehearsals we would make those guys run through. But then, man, when we got on the objective, we maybe only had to be there 45 minutes and we were home, playing Xbox. That was my later deployments. We weren't doing that in my early deployments, but in later deployments, like, yeah, because of those rehearsals. And so that's where I think, like, I'm still for all that technology. I think there's a place. I think we need to prioritize it because there are those situations like the Bronx, Lebanon, right, where it could be 2 years till that person comes back, right? And I need all the help I can get. You know what I mean? Like remembering some of these individuals. Plus, we're getting more and more built on systems. So it's multiple campuses, right? And so, I'm talking to places with 27 facilities or 27 medical facilities, right? And so, if somebody's short staffed, you could be getting floated to a different campus that you've never worked. These pieces are much more plug and play as the system grows, right? So I could go to work at campus X and get sent to campus Y, right? I don't know. I might know some of their knuckle draggers or knuckleheads, but I don't know all of them, right? And so I do think we can build in a lot of redundancy with technology. So I'm still for it. I just think my industry can get hung up and miss the training opportunities in between those upgrades.
Well, yeah, it would be preventative. It would be
right.
It would de-escalate, like we were saying. Like, yes, you want an airbag in your car, but you don't want to have to use it. Right. Yeah, great. I don't want to have to put a new airbag in and fix dents. It's like, do I want one? Yeah, for sure. But I'd rather train the driver to hit the brakes and turn.
Yeah.
Yeah, that's
like I'll have old school, maybe not so much in the healthcare industry, but I'll have old school like security experts. If I put out, I started what I write on LinkedIn is because for probably 6 or 7 years I've helped with a class for nurses on how to respond to active shooters, and I like I spent 50% of it trying to prevent them, right? Because I'll say this all the time: if I ever prevent an active shooter, it's because I encouraged a nurse to speak up. Right, because they know their department, they know their coworkers, they know their patients, they know the grievances, right? Like empowering them to know what to look for is one of the most important things I do personally. And my wife has been on me as a nurse to say, like, hey, you should offer this to other, right? And so for now, I don't have any online courses. I've just been putting it out on LinkedIn for free just to see what resonates, what helps, test the curriculum. And what I'm seeing is totally forgot where I was going with that. Hopefully you can edit this crap out.
Well, I got to be honest with you. I would pitch you on online courses because if there's one thing, if you just started recording your ideas into your iPhone, which is what I do now. I don't do anything without recording it. And then I drop it into an AI program that helps me summarize it, break it down, find the primary keywords, find the primary takeaways. And then I'll usually drop it into another piece of AI that I've sort of pre-formatted to say, hey, when I bring you information, I want you to spit out this. And so I run all my notes become a living thing then, kind of, and ideas evolve on themselves. What I recommend for people who have any inclination, I've got a friend who is writing a book. I'm like, it's already written. I said, read it, record it, read it and record it into a phone.
Okay.
And let's have AI turn it into a course.
Nice.
And so for you personally, like if you're interested in taking a worthy message, like let's take that offline. Like I'm either going to be able to help you, totally turn you off to the idea when I present you with what I think it looks like, or B, give you a great idea and help you find the right resources to do it.
Yeah.
Like, because that's probably not me.
Right.
Kind of thing. But I know there's stepping stones that are available today that weren't even available a year ago for looking at it from the chair of, okay, you as a consultant, great, you can probably sell a ton of this stuff out there. You as within this system, this is the type of process using AI that would allow you to create standardized workflow type modules. For example, that communicate various parts of your outline based on building A in the system, building B in the system, and that you've almost got like curriculum is a weird word to use, but like, oh, I'm going to be in that building tomorrow. I should jump on the thing and run through the modules for that building so that I don't waste 5 minutes getting in or finding my place, doing this or that, like getting in front. It's for that from the perspective of that person who's being transferred from one building or one campus to another. That's the bartender looking at them in the eye saying, hey, I can't get to you right this second, but here's this'll get you through for the next 10 minutes. Like, welcome to the bar. So it's like almost the same thing. Somebody in your organization doesn't really need a personal person greeting them at the door and saying, I know it's your first time here. We're short staffed. It's been a mess. It could just be the de facto thing on the company intranet or the company app or something. It's like, oh, are you in this location? These are your modules. Are you in this location? These are your modules. And having been trained on what those modules mean at their own location, they now know how to apply it in a new location that has maybe a different layout, employs different technology or something like that.
No, that's awesome. Yeah. And if you want, I can finish that thought too. I'll definitely would love to follow up with you offline on,
Finish that thought.
Well, yeah. So some of these old school security guys will be like, there's really no business in teaching staff like run, hide, fight. Like it's not their job, right? Like we should create such a secure environment, right, that they don't have to do that. And man, I wish I could. I wish I could. That's a
model. Yeah, that's a model.
However, right, this person could walk out of the hospital and be at the grocery store tonight and walk into an active shooter, right? And so, to me, there's still a place for training these people. And I think it's also like looking at like, what are a lot of our heart issues, right? Like, we're overweight, we're unhealthy, we don't eat right, we don't exercise, we don't control stress, we don't sleep enough, right? All those things, right? Well, does that mean we stop training paramedics, right? Because, do we just dump, the EMS system? Because realistically, what would solve a lot of those issues is addressing those other issues. Like, I think there's still a place for that profession, right? I think there's still a place for these emergencies, right? We still want them able to respond. So I think we can look at address those bigger picture issues while also training staff that like, hey, if X happens, right? Like here's your battle drill, right? Like run, hide, or fight, or and there's I'm not sold to any certain model, but like
I am
just some kind of training.
I'm sold to the model where all the staff is invested and all the staff is trained. You know why?
Yep.
I bet your retention goes up. If you're the hospital with that model where person A knows, person B knows what they're doing. If I've got my back turned and something pops off, everybody I work with can handle.
They know the playbook.
Their process, their piece of the process to lock this place down.
They know where they're going.
Whatever to whatever. I'll tell you right now, that's the model. Versus this place versus you having detectors and like a squad at every entrance door, because that's really the other option, and that's fine if it's so protected that nobody ever has a worry. But like, how are people even going to get in the emergency room because you're promising me everybody trained at such a high level and it's still such a confidence in a culture that you're not going to get if it's just you're within a walled city. And don't worry, the ex-special forces guys at every entrance to the hospital are going to keep you safe. That's great. That's actually pretty comforting.
Yeah. The best nurse managers I work with they integrate this in their quarterly meetings. They integrate this in their huddles, like the morning huddles, right, that they do throughout the week. Like, they keep this stuff at the forefront. And so they hold us accountable. That's like, yeah, you're right. You know what? We should review, how to use the chairs to get patients down the stairs, right? Like, it has been a minute, and so, I think there's some opportunity there within security, within police, to be proactively training. And then also with these the best nurse managers, they're keeping it in the forefront and they're forcing their staff to train on this. And it makes all the difference when things happen.
I'd be less anxious, and I think I'd be more interested in staying in a hospital system that had that culture than being like, my friend's like, oh, you should come work in our hospital system. And I'm like, well, everybody on my end is really like, we have a whole security protocol and everybody knows what they're doing. Do you guys do that? If they're like, no, be like, I'm good with a commute that's 15 minutes longer. I work for a dude, but I check rooms, and situational awareness matters to me. That would be night and day in terms of how I value my employment at that place versus a place that didn't have that culture.
Yep. I work with people who at various campuses who I believe the city I'm in, we have better police and security than our competitors, in my opinion. And as a whole, both training and just people and personnel, and it keeps their staff who could go make more potentially elsewhere, but they stay because of the culture of safety and the priority of well-trained police. And, while we could upgrade our technology, I'm sure, it does help with staff retention, undoubtedly.
I'm sure. What have we missed?
I think we still need to, I just hope people stay up on this story, this UPMC story. I hope people, because at some point they're going to have to come out with the details, right? Like, there's been very little on it, but I do hope, your listeners, like, they hunt this down, they stay up on this story, because I'm afraid this is more on the front end of what's to come. Other countries, have been down this road, but like,
Well, any soft target right now, I think, again, not to be hyperbolic and I certainly don't want to talk politics, but there's enough people that we don't know in this country right now that you could orchestrate 300 school shootings on the same day.
Yeah.
You could orchestrate 300 hospital shootings on the same day. Right. My concern for what we're facing in the next decade has never been greater. Because we have, I want to say the gotaways are 2 million. The people we know are absolutely terror affiliated are in the thousands.
Right.
How many people? 9/11, 19? Not counting the CIA and the FBI. How many? 19.
Right.
You're telling me 2,000 terrorist affiliated people running around this country can't do 300 hospitals in a day? That's a corporate Nextel account and a bunch of guns is what you need to pull that off. Everybody get your walkie-talkies, sync your watches. Like, it's to be considerate of hardening soft targets right now is, to me, mandatory. I think hospitals and schools are the low-hanging fruit on both ends of the conversation. If I wanted to be a terrible person and I hated America, like I said, I'd go recruit any number of the people who hate America who snuck in for that purpose in the last few years, and I'd orchestrate some horrid stuff. So and then I blame it on somebody else is what I'd do.
Right.
But I think it's going to get bad before it gets worse, is what I'm saying. Long story short, I think we're going to see more of this. I think hospitals, unfortunately, are on the list, and that's just as disgusting because, you know, as I was saying before, there's a helpless person down there in a bed, literally can't lift a hand to defend them. Like, that to me is the ultimate vulnerable person.
It is.
Children then are in the conversation.
Absolutely.
There's a weird thing in this country we do where does this exist with hospitals and healthcare? Because there's an active conversation around where there's an element in this country who's fighting to make sure schools are not protected. They're fighting to make sure schools are unprotected zones. We don't want anybody anywhere near the school with a gun, so that if somebody shows up with a gun, they can go hog wild with impunity. What? That's dumber than natural immunity doesn't work. Like, these are the conversations that make me angry because they're an insult to your intelligence. You're telling me these kids are important, but your actions tell me these kids aren't worth spit.
Right.
I mean, so, and you know, I've seen the numbers, what it would take to put somebody in every single school in the country for 8K. And by somebody, I mean like somewhere in the neighborhood of 3,500 or 4,000 special forces or something. Like, I forget what the number was. This is crazy. But the budget was a fraction of other budgets that exist within our federal government. Now, I'm all for that kind of thing, but is there an element that specifically fights against protecting hospitals because guns make them sad, because they don't understand guns, or because they haven't done the prerequisite work to even use the correct terminology in a conversation about guns? And we'll use phrases like semi-automatic assault rifle. Like, there's that element dictating gun posture without taking the time to learn what the words mean while they're trying to present their argument, to me, is one of the most outlandish anti-intellectual pursuits that there is currently.
I think in healthcare, the biggest limitation is the margins that they're under, you know, financial. I think a lot of the executives I've worked with, they want to do things, but I've even seen them fail to install protection for themselves, because if I haven't done certain things for the facility, I don't want it to perceive like I'm taking care of myself, which I respect undoubtedly. But I think right now, I just think it is so competitive in healthcare, and the margins are so low and so tight right now that, because I think even if they don't want to do it for the right reasons, they want to do it for retention, right? Because the cost of turnover with nurses turning over is astronomical, right? And so if they can create a safe environment to drive down turnover, it's fiscally, it is very advantageous to them. So to me, I still just think like a lot of it comes down to like simply a lack of budgets. And but in the post I wrote on Tosha, right, like, how much is UPMC paying now, right? Because it seems to me like there's an emergency deployment of metal detectors. It seems like an emergency deployment of a visitor management system. Like, it seems like there's a lot of overtime for these officers, reputational costs. How many operational losses did they lose while these facilities were down and people on their ERs on reroute, right? So to me, I think if we thought through what we will lose in the coming 10 years as a result of these types of events, perhaps they'd be willing to spend a little bit more now.
Even turnover.
Yeah.
I would guarantee, and I don't know how you'd measure it, but I guarantee your downstream turnover rate in a facility that's had a freaking shooting hostage event.
Yep.
I'll bet there's people who thought they had 10 years left who are like, I got like 3 years left.
Yep.
There is no way that doesn't affect the culture, and there's no way the culture doesn't affect the turnover.
I mean, the crazy thing is, like, I mean, think about this. Like, these nurses were zip tied, right, and like used as human shields in our ER. And I kind of think it's probably way too early for me to make this forecast, but I half wonder if this dude was more of like a very glorified suicide by cop, right? Because this went on 38 minutes, and he never fatally shot any of. You know, he shot at the police, but he didn't fatally shoot any of the staff. And so but there's time for it. Absolutely. Now there's times where he put this gun to the back of the Jessica's head and pulled the trigger 3 times and it was empty. Now, did he know that already, right? Or was that like divine intervention? Probably never know. But
he exchanged rounds with the police.
He exchanged rounds. Yeah.
Chambered.
He was shooting with police, but I'm just saying, like, hey, this went on 38 minutes and there's no staff fatalities, right? Like,
yeah.
I think we were more lucky than good here. I think this dude was doing kind of like punishing at the staff for the loss. And then I think he ultimately, this was his way to go out like suicide by cop in a very extreme, sick, horrible route. I don't know. Like, I'm working with Facebook posts and one attorney or, one brief, but, and while this is going on, like there's something came out today from like the local news there. While this is going on at less than 5 miles away, there was at Wellspan, York, they had a patient break, I don't know if it's the window glass, some type of glass, and was using it as a weapon.
I knew you were going to say that. Yeah,
he was using it as a weapon to the point like, and they just know off of like court records that they charged him with vandalism, and I don't think any staff were hurt. They were able to, they have like I think they call it a BERT team, like a type of behavioral health team that responds with security that's specially trained and, at another level for de-escalation, and they were able to de-escalate this situation. But literally within 5 miles, you have these 2 incidents going on concurrently. Just to put it, just how much more frequently these types of incidents are happening.
Yeah, that's the York, Pennsylvania sample in a day.
Yep.
So,
on a Saturday.
Yeah. So what happened in Memphis, St. Louis, Philly, Tampa?
Right. Exactly.
Yeah. All right. More action. Afghanistan or Tampa?
Yeah. Say Tampa.
Yeah, that's like Tampa's not even on the list of the more rowdiest places.
It was a pretty docile crowd, if I'm honest.
In Florida.
Yeah, I was.
Well, and I'm really fascinating. You mentioned Mel Cortez again, and that's TACT book.
Yeah, TACT book. Mel's a nurse who had a really violent incident in Baltimore. I know you won't really believe that, and ultimately led to nonprofit she's created and some great work in the training space, I think, for bedside staff especially. Seems to be their wheelhouse.
There is more opportunity, like it's easier to leverage and create your own media in an organized way right now. So I think you're going to see more and more of like people like her, people like you, not only managing to use their knowledge within an organization, but to package it and disseminate it in what either looks like a course or, a seminar, or even something that, could eventually get certified, or even be what would be considered like a continuing legal education training type thing for security officers in healthcare kind of thing. So, I think keep your eye on that too. Let's talk about that, because a guy like you probably has already written a book.
Right.
You maybe just didn't necessarily organize it, and AI is really good at that. Like, I'm not saying it comes up with squat. I'm just saying it's really good for helping you reorder the presentation of things into a way that it helps you figure, I would have never, like, there's just advantages and efficiencies to it.
It's impressive.
What was that?
I said it's impressive, what little I have seen so far.
Very it's wild. All right, with that, we might circle back, though. I appreciate you coming on, Cole, just with a quick LinkedIn invite and explaining to me. I was sure it was, not a cool topic, but it seemed to be a niche conversation that might be really interesting, and I'm sure it's ubiquitous from New Jersey to California. So
I appreciate you sharing that story. Yes.
Yeah, you work in Pennsylvania, and I would imagine you consult anywhere, right?
Yeah, anywhere. Yep, I've been a part of training with like SWAT teams, former Army Special Operations company from New Jersey, actually, did a lot of work in New Jersey to California. So yeah, I have a stand store we can put, in there where you have a newsletter, throw out a lot of this stuff for free. And, or if you want to jump on a call, if there's anything I can do to help, I'm happy to do it.
What website? Where can they go sign up for your newsletter?
It's just, I'm most active on LinkedIn, and then it's just stand store, and Matt Wainscott. If they just type it, Matt Wainscott, Google Matt Wainscott, it'll pop right up. But it's a stand store there. So.
All right, and then make sure you get me some links for GoFundMe's for the York incident, and
I will.
No promises, but it's certainly a worthy cause. Your topic is certainly an interesting. Again, I think we both agree, timely, and we'll have more focus on it, unfortunately, in the future, I would assume. But thank you for your time, and you're welcome back anytime.
Thank you so much, Tom. I appreciate you sharing their story.
The best way to follow, subscribe, rate, or message the show is to visit njcriminalpodcast.com.
For information about podcasting, go to nichepodcastpodcast.com. For legal podcasting, visit legalpodcasting.com.